Dr. Strong, you now have the floor.
Thank you very much, Tim. It's a pleasure to be here again with you for this webinar hosted by Microdental. Today, we want to deal with prosthetic aspects of all-on-4 cases, and we want to present both the digital workflow and the traditional workflow. First of all, let's explore exactly what we mean by an all-on-4 type of case. In this scenario, 4 implants, typically, possibly more, but usually 4 implants are placed in the maxilla or the mandible, often with little to no grafting. The 2 anterior implants are placed in the traditional vertical positions, but the 2 posterior implants are placed in a tilted or a posteriorly angulated position to create a truss form for the final appliance. Teeth may be extracted prior to this, and then the implants are placed. Once the implants are in position, then we will have these abutments connected into the implants. These are called multi-unit abutments that allow us to build our appliances on these abutments. The abutments are angled depending on the angulation of the implants, and typically the posterior implants, being more tilted, require more angulation for the multi-unit abutments. What we're doing there is basically paralleling up the path of insertion for our appliances. Everything that we build from that point in will be connected to these multi-unit abutments. What we're viewing here are titanium cylinders, and these are connected with additional screws into the multi-unit abutments. The titanium cylinders will serve as connection options for our temporary appliance. These will be connected or picked up in a pre-made denture appliance. Holes will be drilled into the denture, exposing the titanium cylinders. Then once the denture is in position with the correct occlusion that's been checked, then these titanium cylinders will be picked up with either cold cure or autopolymerizing acrylic or light cured material. But once again, those titanium cylinders will then become part of this denture. The denture will then be converted by a series of laboratory procedures. So once the titanium cylinders are connected to the denture base, then the denture itself will be reformed with the palatal area cut out, the flanges cut down, and through quite a bit of laboratory work, the denture will be converted to a temporary bolt-down appliance that is then delivered to the patient. The patient is able to walk out of the operatory with a bolt-down, stable anesthetic appliance. So I wanted to illustrate that sort of procedure with these animations first to give you a little flavor for the conversion to a temporary appliance. Now let's look at doing this clinically. So here we have 2 dentures, 2 immediate dentures, if you will, that we have constructed. The patient will have all of the remaining maxillary and mandibular teeth removed, and these dentures will then be fitted and converted to the bolt-down temporary all-on-4 appliances. You see some ball clasps that allow us to connect those dentures together intraorally so that we can maintain the patient's vertical dimension and occlusion. It is important that the implants are going to be stable for us to be able to convert to a bolt-down appliance. So the implants will be torque tested to confirm that they are stable enough for us to do this procedure. Here we are at the time of surgery. Teeth have been removed, and quite a bit of alveolus in some cases will also be removed. If we close up a little bit, you see a replica of the maxillary denture in place here. And you can also notice that this is the approximate amount of alveolar removal, crestal removal, that is being done to give us enough room to build the final all-on-4 appliance with a titanium bar as well as adequate thickness of acrylic to give it strength against breakage. We're looking now at the upper and lower dentures, which have been relined with an impression material over the multi-unit abutments. So you can see these access openings here are imprints of the multi-unit abutments. The denture will now have holes cut through those areas to expose the titanium cylinders that will be connected to the multi-unit abutments. So the upper and the lower dentures will have these holes drilled out so we can then place the denture intraorally and visualize the titanium cylinders. Here we have 2 holes cut in the maxillary and 2 holes in the mandibular to expose the anterior titanium cylinders. In our procedures, the anterior most cylinders are connected or picked up first, and then we go back and pick up the posterior titanium cylinders. Here we have 2 titanium cylinders that have been connected into the multi-unit abutments. As you can see, the tissues have been sutured together, and we're ready to do the pickup procedure with acrylic material. Again, those temporary cylinders will be picked up with acrylic in the denture base. Here showing the mandibular option. On the maxillary option, we see one of the holes cut very well, and you see the titanium cylinder extruding through that denture base. At this point, some auto-preliminarizing self-cure acrylic has been mixed, monomer and powder mixed to a fairly thin consistency, placed into a monoject syringe, and that will then be injected by the surgical dentist, in this case, into the denture base and around the titanium cylinders. You can also use a light cure material if you prefer that type of material, whatever your choice is for picking up the titanium cylinders. Before the denture is actually removed from the mouth, then we also get a new bite registration at the proper vertical dimension, because much of the remaining procedure will be done extraorally or indirectly in a laboratory procedure while the patient waits for us to convert the denture. So bite registration material here, as you see. Then the dentures are unscrewed. The titanium cylinders have been connected into the multi-unit abutments with their own screws. By loosening and unscrewing those, we've now removed the maxillary and the mandibular dentures. In the laboratory, we now have connected the analogs into the titanium cylinders. These are analogs or replicas of the multi-unit abutments. So at this point, we now have in hand a new bite registration. We have previously mounted the dentures with a face bow on a semi-adjustable articulator, and we will now be doing all of our laboratory work with the mountings from that the previously mounted dentures. We have now boxed the dentures with the multi-unit abutment analogs and titanium cylinders in place, and now we'll pour casts in a fast setting stone to be able to give us new working cast for our conversion from the full dentures into the temporary all-on-4s. The impression is also mixed or poured with a fast setting stone and slurry water to further accelerate the stone set. So we'll get set stone in about 10 to 15 minutes. We've now separated that impression and cast with the denture connected to it. Here we have the red circle around the maxillary cast. And we will be able to remount that to the original mounting that we had because we have made an occlusal index from the original mounting of the dentures. So we will mount the upper cast to the occlusal index and then mount the lower cast to the upper with the bite registration that we've made in the mouth. Once that is all set, we now have mounted casts and dentures in place ready for the conversion from the dentures into the temporary all-on-4s. Here, the technician that's working with us is making a Siltec shim around the facial portion of all of the denture. And that will be used as a stop as we reline the tissue side of the dentures. So we've got our Siltec shims in place. And it's time now to cut down the dentures. So we'll cut off the posterior portions, we'll cut out the palate, and quite a bit of the flange. Once that is all trimmed, we have now reconnected the former dentures to the cast that we have poured. And so you can see quite a bit of space from the tissue side of the denture to the newly formed ridge after the alveolar reduction. We will fill in that deficit with cold cure acrylic. So with those dentures that have been cut down, bolted into the new master cast, if you will, we're mixing up a new mix of self-curing acrylic, and then that will be injected underneath the remainder of the appliance. And again, using that Siltec shim as a facial stop to hold the placement of the reline acrylic in place. Once we've gotten all of that injected underneath, as well as added some tooth-colored acrylic around some of the access openings. This here, where the cursor is moving, shows a lot of the excess acrylic that has been used to line the tissue side of the temporary all-on-4. All of that, including the cast, will then be placed into a pressure pot at 30 psi into a pressure pot for about 10 minutes to accelerate the curing of the acrylic and also to give it a denser consistency. We've now removed the cured acrylic and temporary all-on-4s from the casts. And at this point, we will start trimming and contouring this excess material, both lingual and facial, to simulate the final temporary all-on-4s. Once we've cut that away, the remainder of what is now the new temporary all-on-4 is polished with an abrasive polisher, and then standard pumice is used to finish the polishing process, just as we would a full denture. Prior to returning these newly converted temporary all-on-4s to the mouth, we will also have a mouth guard constructed. So from day one, we want the patient to start using a mouth guard for both arches during sleeping periods. Mouth guard is trimmed and polished as well in the conventional method. And here we have the final polished tissue side of one of the temporary all-on-4s. Notice the smooth and convex surfaces that are important to allow us to minimize the amount of food collection or debris collection on the tissue side. Here we have the upper left maxillary converted temporary all-on-4, lower right the converted temporary mandibular all-on-4. ready to return to the mouth. They're placed in a disinfecting type of solution, and you see the screws that allow us to bolt the temporary appliances into the multi-unit abutments in the mouth. So this whole procedure constitutes about an hour and a half to 2 hours, plus or minus, while the patient is just awaiting having these returned. Here we see the maxillary and the mandibular temporary all-on-4s reconnected to the multi-unit abutments. Occlusion has been adjusted, and the patient is ready to be dismissed. One of the things I'd like to point out, I do like to have a little bit of an overjet, not with very little, if any, overbite. So I want to avoid connection with the anterior forward teeth to avoid breakage of those teeth while the patient's in their temporary. I do want to use a lingualized occlusion approach if possible, and also to provide some cuspid disclusion when the patient moves in excursive movements. So this is the way the patient goes home. This was taken about a week after the surgical procedure. And a few other views. So what we typically can wind up with is a very aesthetic smile line, good lip support, and good occlusion. One of the things that's also attractive about the all-on-4 procedure is any items that we see that are not acceptable in the temporary all-on-4 serve as very good references for us to change those items when we go into the final all-on-4. Of course, these temporary all-on-4s do not have a metal or a bar reinforcement, so the patient is advised to stay on a very soft diet for at least 2 months or more, and is strongly urged to use their mouth guard every night or every time during sleeping periods to minimize any damage to the temporary acrylic all-on-4. So we've illustrated the conversion process of the all-on-4. Now let's look at how we make the final appliances. I want to illustrate 2 workflows here. One on the left being the traditional workflow, and the one on the right will illustrate an expedited workflow also using digital technology. But I want to illustrate the traditional workflow first with this case. And this is the beginning condition prior to doing the all-on-4 procedure for this patient. The patient was already in a maxillary overdenture that was unacceptable, and she had not been restored on the mandibular arch. So as always, after a thorough conversation with her options, that being dentures, overdentures, or hybrids, the patient ultimately agreed or stated that she wanted to proceed with a maxillary and mandibular all-on-4 format. The black circles here indicating where she had fractured denture teeth out of her overdenture. Previously, she had these 4 implants in place. By the time she came to our office, she had already lost 1 of them, and those implants were severely angulated. So to complete the treatment plan of a maxillary and a mandibular all-on-4, all the teeth were removed, and those 3 remaining implants were removed. We went through the same procedure we just illustrated to convert dentures to temporary all-on-4s, including maxillary and mandibular mouth guards. So the patient is in these temporary all-on-4s or provisional appliances for approximately 4 months. And at the conclusion of that time, the implants are torque tested and deemed ready to go through the procedures for the final all-on-4 prosthetic appliance. Again, we're going to illustrate a traditional workflow here with 5 appointments to go from an abutment level impression, the multi-unit abutment level, to delivery. First of all, the temporary all-on-4s are removed, and we expose the multi-unit abutments. So therefore, we're going to make an abutment level impression. This will be done by connecting long open tray impression copings to the multi-unit abutments, excuse me. And as you see in the photo here, those long pins and impression copings have also been strutted together with metal struts. And then what you see here is auto-curing GC pattern resin connected around those metal struts. We will make an open tray impression using light and heavy viscosity honeycomb fast set vinyl siloxane material. So with one assistant using retractors to open the field up for me, I'm injecting light viscosity honeycomb material fast set around all of the impression copings and also getting that up underneath the struts as much as possible. Those retractors will stay in place while I then insert my tray that has already had holes cut through it so that I can have the long pins extrude through the impression tray. As soon as I get that in place, you see the second assistant coming in and quickly cleaning away the tray material so that we can visualize all of those long pins before the impression material is set. The impression material is allowed to go to full set. And of course, as I said, we should be able to visualize all of the pins. To remove the impression for an open tray impression, we have to unscrew all of the pins. Here you see me using the Nobel Unigrip hand wrench, but then reverting to my contra-angle wrench, which is really essential in many of these types of cases for me to be able to get access to particularly the posterior areas. So once we removed all of those long pin screws, we can now remove the impression, which has embedded in it all the open tray impression copings and the struts. We can then pour master cast into this impression. Either send that to your lab or pour it in your own lab. Today, what you're looking at is an example of the strutted open tray impression copings, but today I like to use light cured flowable composite because it's so much more user-friendly, quicker, and it actually distorts less than the cold cure acrylics that we used in the past. So here we have our maxillary and mandibular impressions from which we pour our master cast. So all of that occurred at the first appointment and then the lab work to construct the master cast. Our next appointment will be involved in our records appointment to get our centric relation, our incisal edge position, and also to confirm the accuracy of our cast. So at the second appointment, I'm typically going to do a face bow and a jaw relation record, and also try in an AVJ, an acrylic verification jig. The acrylic verification jig allows us to confirm the accuracy of our master cast, which is very important since we're going to make a milled titanium bar eventually. In the mouth, the acrylic verification jig is placed with one screw on one end, and we confirm by pushing down throughout the length of the acrylic jig or bar that there's no movement of that jig. If we do that from one end to the other and then reverse the screw to the other side and confirm that there's no movement, then we can confirm that there is that we do have an accurate master cast, and we should be able to build our bar accurately as well for a passive fit of the titanium milled bar. Now, many of you, many of us, will get our centric relation records with the traditional wax rims and base plates, and you may manipulate those base plates into position, which I will do for the maxillary in order to get an incisal edge position and lip support. But what you're looking at here is a Gothic arch tracing, and that allows me to get centric relation at the correct occlusal vertical dimension. The cursor here is showing the tip of an arrow or a Gothic arch tracing, and the tip of that arrow now isolated with this plate with a hole in it. The tip of that arrow illustrates or constitutes centric relation for that patient. And at our next webinar, which will be focusing on overdentures, I will go into more detail about the use of the Gothic arch tracing, how we do that, and how we obtain centric relation at the correct vertical dimension. In the lab, we've now mounted our master casts with our records, and we now have our maxillary and mandibular master cast illustrated here. One item that is important at the surgical procedure is to determine that we will have at least 17 millimeters from the incisal edge position to the residual or newly created alveolus. If we have much less than that inter-arch space, it becomes very difficult to have an adequate thickness of acrylic for our denture base wrapped around our titanium bar. And I hope to be able to have time to show you an example of that later on. Moving on now at this time, the laboratory will have set denture teeth in wax as we would for any type of denture construction, and we will have that returned back to us. We will try those setups in the mouth before we fabricate the titanium bar. We want to make sure that all of these items on the right, occlusion, etc., are satisfied by us and the patient before we move on to construct the bar. Here we have an example of the retracted occlusion. Once we've approved the setup, then we can go and make our titanium bar. Now, theoretically, because you have vetted the master cast with your acrylic verification jig, perhaps we don't have to have a verification or a try-in of the bar, but particularly in your early uses or early cases of all-on-4s, I would strongly suggest that you have the bar made and just try it in and make sure that it is a passive fit, a correct fit, not only by digital one-screw test as we did with the AVJ, but also with a radiograph. One item of note to determine how far we can cantilever the bar posteriorly is the AP spread. So if the distance between the anterior and posterior implants is measured, we can cantilever the bar 1.5 times that distance. So if the red arrow happens to be 6 millimeters in measurement, we can cantilever the bar back to as much as 9 millimeters. Here you also see radiographic confirmation with a panoramic x-ray of the bars before we go ahead and finish the case. And you're also looking at Nobel Biocare speedy and active implants in combination. Once we've approved our setups and we've confirmed that our bars fit, we can have the laboratory process the standard denture acrylic around the titanium. We call it a wraparound procedure. In addition, new mouth guards are made, and here we have the wraparound all-on-4 hybrids ready for insertion. And so what you're looking at here is conventional processed acrylic and denture teeth wrapped around a titanium bar. Insertion, day of delivery, and retracted view of the all-on-4s in occlusion. Now our second case is a little different. We're still going to go to a final all-on-4 prosthetics after conversion of dentures into the temporary all-on-4s, but we're going to use quite a different procedure. We're going to do what we call the expedited digital workflow. And in this workflow, we will be able to reduce the number of appointments from 5 to 3. Essentially, we're going to be combining the first 2 appointments from the traditional workflow, our master impression and our records, into one appointment. This appointment will take longer for you to accomplish in your operatory, and perhaps you will want to share that with or have some of that done with you with a lab technician. We're also going to ultimately use fully milled acrylic. So we're not actually going to have denture teeth anymore. Everything that you're going to look at in the final appliance is completely milled. And I'll speak to that more as we go through it. Here we have the preoperative condition of the patient. Lots of wear, lots of cervical as well as interproximal caries. Patient has an extremely dry mouth due to medications as well as hepatitis C. He survived that problem and once again became able to move forward with addressing his dental condition. So as I've stated previously, we went through all of the options for the patient: extraction of teeth, dentures, overdentures, or all-on-4 type hybrids. All of those red arrows that you're looking at indicate recurrent decay in and around existing crowns or existing restorations, as well as we have decay in the incisal areas of all the maxillary and mandibular anterior teeth. Here we are preoperatively before teeth are removed. And so, as we've seen in the previous cases, maxillary and mandibular teeth will all be removed, 4 implants placed on each arch, and the dentures that we will construct prior to extraction of the teeth will then be converted to the provisional or temporary all-on-4s. So we've gone from the preoperative case to completion of the provisional all-on-4s. A very nice, pleasing look. We've got very good lip support, a good incisal edge position, and good occlusion at a very comfortable occlusal vertical dimension. And so in many of these cases, when everything looks good, or for the most part looks good with our provisionals, our task is simply to copy those contours, the occlusion, the buccal corridor, and the lip support in our final appliance. Closer up look at the provisionals in smile as well as in retracted view. And we also are able to confirm from the patient if the shade of the denture teeth themselves is acceptable or whether they would like for them to be darker, lighter, or have some arrangement changed in the setups. So let's look at the first appointment for this digital expedited workflow. I'm going to ask you to really focus with me for a minute because that first appointment is fairly laborious and time consuming. So first of all, the first requirement to be able to do this expedited technique is to confirm that the temporary all-on-4s and their titanium cylinders that are contained within them are fully seated, because we're actually going to be making an open tray impression of the temporary all-on-4s, and that's going to form our master cast, as opposed to taking those out and putting in open tray impression copings with long pins. The only thing we're going to change about the temporaries is we're going to substitute one by one the retaining screws for each titanium cylinder and place in a long impression pin that will allow that pin to extrude through our open tray impression tray. Again, you're looking at Nobel speedy and active implants. Now, the first thing I will do at this first appointment is make 2 of 4 impressions. Ultimately, I'll be making 4 impressions for this appointment. What I've done here is to make standard impressions, either alginate or VPS impressions, of the existing temporary all-on-4s. I haven't put in my open tray pins at this point. I will take those impressions to the lab along with a face bow and a bite registration that I've made, and mount the maxillary, pour those impressions. And then once those impressions are set, I will mount the maxillary cast using the face bow to a semi-adjustable articulator. And once that mounting stone is set, using the bite registration that I've made, I will mount the lower stone cast of the temporary all-on-4 to the just recently mounted upper cast. So I wind up with stone cast of the temporary all-on-4s at the correct vertical dimension that has been approved by me and the patient. And I want to then use that to cross mount my next set of models. While all of that is setting, I will go back to the lab, I will go back to the operatory, and I will complete open tray impressions on both the maxillary and the mandibular temporary all-on-4s. I'm going to show you this on the lab bench, so to speak. I'm going to ask you to imagine that the cast you're looking at is actually the mouth, because videoing this impression is somewhat difficult and laborious. So I will illustrate this on the lab bench. Once again, if you envision that the cast is the mouth, we've now substituted long pins into the titanium cylinders. I've cut holes through my impression tray, and then I will make a dual viscosity impression. We will put heavy or rigid VPS material. Once again, this is Honigam from DMG. We'll put that into the impression tray, and then first in the mouth, I will inject light viscosity all around the temporary all-on-4, being very conscientious to try to get that impression material squirted or injected up under the tissue side as much as possible, because I want to pick up that area in my final impression. Once the light viscosity is in place, the impression tray is inserted. And as you saw in the previous impression, very quickly we want to dig down through the impression material and expose or visualize the tips of those long impression pins. Once the impression is set, we unscrew the long pins and remove the impression from the mouth, and we will have picked up in the impression the patient's temporary all-on-4. We have already done a face bow and a bite registration as well to allow us to mount all of this on our semi-adjustable articulator. Now, either in this case, I will do this, or you could hire a laboratory technician to come in and do this part of the lab procedure. I will connect multi-unit analogs or replicas to the titanium cylinders in preparation for pouring the master cast. I'll lubricate this impression material, and first I will inject soft tissue material all around these analogs and let that set. And that only takes a few minutes. And then I will pour impression material dye stone over that. While all of this is going on, the technician will be basically alone under supervision in an operatory. You want to make sure that you place these white healing caps onto these multi-unit abutments, because the patient will be in the operatory with no temporary in place for at least an hour, perhaps more. And if you don't put those white caps in place, the tissue will collapse over those multi-unit abutments, and it will greatly impede your ability to reseat the temporary all-on-4. Now, with my previously mounted models, once my soft tissue and stone cast is set, I will then remove the upper stone cast from the articulator. With the bite registration, I will mount the new maxillary master cast with the temporary all-on-4 in place. Once that mounting stone is set, I will mount the mandibular master cast with the temporary all-on-4 to the newly mounted maxillary cast with the temporary all-on-4. And I'll wind up with both temporary all-on-4s mounted at the patient's correct vertical dimension.
Dr. Strong. Dr. Strong, can you hear me? Dr. Strong, can you pause, please? Your mic, I believe, is muted.
Okay.
Yes, sorry. Can you repeat that one more time, starting from about a minute ago?
Sure.
Sorry about that. Okay, thank you,
So
everyone.
at this point, now can you hear me?
Yes.
Okay, thank you. Sorry about that. So I'm reverting back to a previous point. I hope I'm picking up where I left off. So one by one, I'll go back one more slide. I will take the maxillary stone cast off, put on the newly poured and set master cast with the temporary all-on-4 in place and mount that against the stone cast of the lower. Once that is set, I will mount the mandibular master cast to the just now mounted maxillary cast, and I'll wind up with the two temporary all-on-4s mounted on the semi-adjustable articulator at the approved vertical dimension. At this point, we can remove the temporary all-on-4s and go back to the operatory and reinsert those back into the mouth. As I previously mentioned, you will need to place white healing caps on those multi-unit abutments while all of your lab work is completed to keep the gingival tissue from collapsing over the multi-unit abutments. So you're looking at the master cast, soft tissue and dye stone material, now with the temporary all-on-4s removed and placed back in the mouth. And here we have the mounting of the maxillary cast showing the interarch space available for us to build our final appliances. And generally speaking, we want at least 17 millimeters per arch from the incisal edge position to the residual ridge. And as measured here, you can see we've got just about that, about 34 millimeters of interarch space for the double jaw case. Now, at this point, the patient goes home with their temporary all-on-4s back in place. A lot of lab work goes on at this point. In this particular case, we won't be doing base plates and wax rims or denture teeth setups. We'll send that to our lab partner who will scan our master cast and our bite registration. And they will bring back to me online what we call a preview, as I will illustrate. The preview is a virtual setup on the computer. I will approve that preview or make changes to it. And once I have finalized and approved the preview, I will get back what we call the hybrid try-in, which is a milled try-in appliance. We will not be trying in denture teeth in wax. We will have a solid try-in that we will be able to use at the second appointment. So following all of that lab work, scanning, virtual setup, and then milling of the try-in, we will have the HTIs, the hybrid try-ins, returned to us. These will be substituted for the temporary all-on-4s and evaluated just as you would for everything that you do for a wax try-in. So here you see an all-white, solid milled try-in. We evaluate everything that we would normally do for dentures, for example. We look at midline, buccal vestibule, lip support, and incisal edge position, et cetera, as well as phonetics. And so we're looking in the lower left at the patient's beginning smile and more animated smile. And we can evaluate how much actual pink acrylic will be exposed when we go into the final appliance. Another very nice feature of the solid try-in is what we call a chew test. So in this case, the patient actually was able to eat an apple or any other type of food that you would like to let them road test, so to speak. So patient actually gets a preview for what it's going to be like with the final appliance in place. Generally speaking, the final all-on-4 will extend at least one tooth farther posteriorly than the temporary all-on-4. Once we approve the try-in, that is returned to the lab. We'll usually get a new bite registration, photos of that, and then the lab goes back to work on the computer. The lab scans any adjustments to the hybrid try-in, scans the new bite registration if there is one, and I will receive once again a new preview in order to evaluate the design for the final bar and the final setup. Here we're looking at the design on the computer from Nobel Biocare of the bar design. I want to pay a lot of attention to how much acrylic I think we'll be able to wrap both above and below the bar, because thickness of the acrylic is an important aspect to preventing breakage. In a different case, we're looking at the virtual setup from Avident. The blue translucent material represents the bar, and then we also see just the denture teeth and where they fit in proximity to the bar. Keep in mind, in this particular case, we will not have individual denture teeth. Everything will be milled from a solid acrylic puck. And here we have, after approval of all the bar and setup, we have the fully milled maxillary and mandibular all-on-4 hybrids. Just a moment about screw positions. These three positions on the upper are excellent. One here gives us a little concern about possible breakage of that thin area adjacent to that mesial portion of the tooth. So we want to evaluate as much as possible where we can get our screw holes to come through to minimize the chances for breakage. Another nice thing that the Avident technology allows us to do is to custom colorize the final denture base. So this is a GC Gradia type staining material that gives us a much more lifelike appearance to the denture base. Once again, just to repeat, you're not looking at denture teeth. These are completely, fully milled out. So you're looking at one solid piece of acrylic from the incisal edge to the flange of the appliance. And the patient with the completed maxillary and mandibular all-on-4s in place. We'll look at where we started before. So the all-on-4 is literally a transformative appliance for patients who have failing dentitions, and it allows them to walk out, even with their temporary, with a greatly improved degree of stability and aesthetics. We've also developed a storage system, so we retain all of the temporary all-on-4s as well as the hybrids in case we ever have to return to those. Now, we're beginning to run out of time, but I certainly want to get in this one case, because in some cases you will wind up with less than ideal inter-arch space. You'll wind up with less than that 17 millimeters. So I want to look at this case. A patient was a previous maxillary conventional denture wearer. We're going to treatment plan all her options once again, and she agreed to a maxillary all-on-4. However, we wound up with far less than our ideal 17 millimeters of inter-arch space. And so we're going to utilize a concept called the Montreal bar. And you can look at that on the website from various entities, including Nobel and others, to illustrate what the Montreal bar, the advantages of that feature. Here we are with the patient. We're going to pick up the patient with her temporary all-on-4 in place, and she is now opposing an overdenture. But our focus right now is going to be on the final all-on-4 procedure. We're going to use the expedited technique once again. So we've confirmed with our panoramic x-ray that the titanium cylinders in her temporary all-on-4 are fully connected into the multi-unit abutments. That's a critical part for successful completion of getting an accurate master cast. And the patient did have 3 implants previously. We had 1 more implant placed so that we could better stabilize her existing lower overdenture. The patient is 92 years old. And so for that and other reasons, I elected to use an alginate material for my first appointment procedure. So I made an open tray impression with alginate and unscrewed those open tray impression pins and removed her temporary All-on-4, as you see here, connected the multi-unit replicas to the titanium cylinders, and poured my soft tissue and stone cast. And unfortunately, we wind up with significantly deficient interarch space, about 11 millimeters versus 17. So we get this preview from Avident showing where our denture teeth can go. We can rotate that preview and look at our interarch space here, or how much room we have to build acrylic and a titanium bar. And as you can see with the cursor, it's very, very limited. I can put a grid on this preview and also very accurately determine how much space in millimeters we have. Each one of those little square boxes is 1 millimeter. So we're going to utilize the Montreal bar because of this issue. But first, at our second appointment, as part of the expedited procedure, we get a milled hybrid try-in, a solid try-in back to us after previewing and approval of the virtual setup. So here we have the patient with her milled try-in in place. And we can adjust that solid try-in as needed. We did determine that we wanted to move the midline 2 millimeters to the patient right, which we were able to do with the software involved in this without having to do another try-in. So that goes back to the lab, and now we're ready to design the bar. The next 2 or 3 slides are going to illustrate in gold what the Montreal bar does. So instead of a wraparound concept, the tissue side of the bar will actually contact the tissue, or almost contact it, whereas in the previous cases, we would wrap acrylic around the bar and we would have the tissue side to be all acrylic. Everything you see in gold there will be the Montreal bar. In this case, the bar is a T-shaped bar with a flange on the facial and the lingual. And again, the tissue side will be completely milled titanium. This look will also illustrate how little acrylic thickness we would have if we wrapped completely around the bar. We blow that up. This allows us to maximize the amount of acrylic that we can have over the titanium bar. So the completed appliance here illustrates the tissue side of the Montreal bar and all of its connections into the multi-unit abutments. By designing that, you also get a very nice emergence profile from the top of the multi-unit abutment, which would be particularly important if you have a subgingivally positioned multi-unit abutment. Radiograph of the completed Montreal bar within the appliance, and also overdenture connection. And a couple of more shots here of the Montreal bar. So if you wind up with an inadequate interarch space, I would strongly recommend that you explore the possibility with your lab of the Montreal bar. Other options could include going to a zirconia. Perhaps you can make the zirconia still strong in a thinner dimension, although there's a limit to that as well. And another option is for you to open the vertical dimension of occlusion. However, in some cases, you can only do that so much without winding up with difficulties in comfort to the patient as well as aesthetics. In this case, we're looking at the upper left, the patient's previous overdenture, with 3 implants in place, we put in one fourth implant and connected that with the new RTX attachments from Zest Dental. And we'll be illustrating those RTX locator attachments along with several other items in our next webinar, which will focus on overdentures as well as centric relation. And I'm going to zip to one more thing. I do want to show the patient's final view. Really a sweet patient, 92 years old, World War II veteran, and they're actually one of the heroes of World War II. And we were thrilled and honored to be able to provide this type of appliance successfully for the patient. I do want to look at 2 more items before we take questions. Cleaning is often a question. How do we clean underneath All-on-4s? And we rely heavily on an irrigation device. We like the HydroFloss, which allows us to generate a pulsing but gentle stream of water, plain water, around the appliance and underneath the appliance in the intaglia to flush out, if you will, any food or debris that might be collected. We have the patient start using the HydroFloss 2 weeks after the surgery. So they are acquainted with this appliance while they're in their temporary appliance as well as the final. And then just a preview for our next webinar. You know, one of our difficult things in prosthetics is gaining a good centric relation for the edentulous patient. Here we have the patient at try-in, and you know, when the patient opens and then closes again, my heart rate is typically going up and up and up, as I'm hoping that they're able to go close back together in a good occlusion. And that's where the Gothic arch tracing, I think, really helps us out, because we can accurately complete the centric relation procedure at the correct vertical dimension over and over again.
Close. One more time. Open. Close. Or open. Open.
As you can see in all of these cases. And so that pretty much fills up our time for the webinar. We want to leave a little time for questions and answers. So at this point, I'll turn the program back to Tin and entertain any questions that you may have.
All right, thank you so much, Dr. Strong. And yes, we will turn it now over to the Q&A portion of this program. I will start with the first question. Is there a torque requirement for being able to provide the patient with a temporary? What are the contraindications for a temporary?
Yes, that's a great question. So at the time of surgery, it's important that the implants themselves torque in to the manufacturer's directions. In the Nobel BioCare family, the implant needs to be torqued in at a minimum of 35 Newton centimeters. Anything less than that would give us a reservation about moving on with the bolt down temporary appliance. Very seldom is that the case. I have had that happen in a couple of instances, and if the implants do not torque in, then we have to just put the patient into the temporary denture until the implants are stable enough. I would want to mention one thing. I just want to, on a different note, I've shown you or illustrated the Avident technology for scanning and milling and digital technology. And so this is one of your choices for digital scanning and milling. You would want to consult with any of the modern dental laboratories, including microdental, about any options you have for engaging in digital scanning and milling technology. Okay, just wanted to get that in.
All right, next question. Can you repeat your comments for cantilever design, please?
Sure. That cantilever requirement is called the AP spread, the anterior posterior spread. So if we simply measure from the anterior implants the two anterior vertical implants. We may take a measurement from those implants to the posterior implants. Whatever that measurement is, we can safely cantilever 1.5 times that measurement. So if the measurement between the anterior and the posterior implants is 6 millimeters, we can cantilever the bar 9 millimeters posteriorly.
All right, next question. What is your technique for torque testing the implants?
Okay, at the time, there's two aspects there. At the time of surgery, prior to placement of the multi-unit abutments, in most cases, we're going to torque test the implants themselves. So the driver can be placed into the implant, the torque wrench applied to it, and confirm that we can apply the required 35 Newton centimeters of force. Generally speaking, when we get to making the final All-on-4, we will simply remove the temporary All-on-4 and torque test the multi-unit abutments. And I would caution you that in the Nobel family, those screws are much smaller than the screws for the titanium cylinders. So those screws torque in at 15 Newton centimeters. So we once again just confirm that we can put 15 Newton centimeters of force on those multi-unit abutments without any movement of the implants and without any sensation to the patient.
All right, next question. If a patient comes in with implants previously placed, how do you deal with the liability of one or more of those implants failing after you have worked on the patient?
That's an excellent question, and it will happen from time to time. So first of all, radiographically, we're going to have to confirm that at least there appears to be good osseointegration. In addition to a panoramic x-ray, if you have the capability, it would be strongly recommended that you get a CBCT done, a cone beam CT done, to confirm that there's good bone integration around the implant. Of course, that can be a little misleading, but at least you want to cover that base. And then you certainly want to get down to the implant. If there's some sort of temporary appliance or crown on the implant, I would want to remove those and subject the implant to a new torque test and confirm that it is integrated, that it can absorb the required amount of force. And then just another item that you would probably want to make sure that you do is that you get a good consent form from the patient acknowledging that the implant was placed by another clinician and that you're not liable for any problems resulting from the surgery. It's a tricky question, and I think we need to, in those types of instances, we have to do everything we possibly can to minimize the amount of liability to yourself.
All right, we will answer 3 more questions. Sorry, our time is limited, but as I mentioned, if you have any questions after the conclusion of this program, you can always email Dr. Strong directly. All right, next one. How long to schedule for your first restorative appointment in the expedited workflow?
The amount of time scheduled for that first appointment, and I think the clinician is very acute there in realizing that's going to be a lengthy appointment. So in my hands, that is at least a 2-hour appointment. For some patients who you may have difficulty getting in and out, you may want to schedule even more than that, maybe an all afternoon or all morning appointment. Mm-hmm. But in general, you want to get in and out in about 2 hours. Now, recognizing that your lab work itself will probably constitute an hour or more by the time you poured models, allowed stone to set, and mounted those models on your articulator. As an alternative option, you might find it more productive to hire a laboratory technician. And once you've removed the temporary All-on-4s with the appropriate face bow and bite registrations and place the white healing caps in place, then you could have the laboratory technician take on all those procedures. Perhaps you could move on to another procedure that's productive. In my hands, I typically do all of that myself in my own laboratory.
All right. Next question. How often do you remove the All-on-4 for professional cleaning?
Yeah, another very good question. So the answer to that varies quite a bit from clinician to clinician or from various authorities. I've certainly seen it recommended that the final All-on-4s should be removed annually. I typically do not do that because I would want to point out that it is a laborious procedure and time consuming. By the time you unscrew an All-on-4, clean it, evaluate it, and certainly x-ray it, and then get it back in place, you're probably going to spend at least an hour. So it's difficult to make a fee that's commensurate with that amount of time. Therefore, I typically remove these only when there's evidence of some bone loss occurring, or visually if we're able to see some stripping of the tissue, if the patient notes quite a bit more food collection underneath the appliance, that could indicate a problem, or if there's any evidence of inflammation. I certainly don't oppose removing the appliances whenever one suspects the need to do so and get under and clean it. One final thing I'd like to note, there's pretty much what is called the 5-appointment rule. So a screw can be safely removed and retorqued in up to 5 times, perhaps not that many, but no more than 5 times before the screw head itself is weakened. And remember, the multi-unit abutment screw torques in only at 15 Newton centimeters. And the cost of those screws is significant. So if you're going to have to remove an appliance and replace screws, the cost of that gets fairly large, and you need to factor that into your fee.
All right, we'll answer the last question. I see that we do have many questions, so our time is limited. So our last question is, do you ever have anterior teeth 8 and 9 break off from upper All-on-4? How do you fix if this happens?
Well, breakage of acrylic is something that's part of your life if you're dealing with that. I don't have experience with zirconia, but that might be an option for you to consider if you're having a lot of that. Yes, with conventional acrylics, I have certainly had fracture of both denture, acrylic base, and denture teeth. I've had far less of that once I have embraced digital milling technology. So the fully milled acrylic is at least 8 times stronger, 8 times more breakage resistant than conventional acrylics. That doesn't mean that even the milled acrylics can't break. My occlusal scheme also in that anterior region is to not allow coupling of the anterior 4 teeth, as I was taught previously I should do. So I do not want those anterior 4 teeth touching in centric relation, and I would like to have no overbite if at all possible. So when the patient moves anteriorly, I want them to barely touch the incisal edges of 8 and 9 with the lower incisals, or not at all. And then one final item is I would like to build the denture teeth to have a fairly good thickness from facial to lingual. If you wind up having ground a lot of the lingual portion as well as the incisal edge portion to adjust occlusion, even with any kind of acrylic, you're going to be more subject to breakage. The repair for that with conventional acrylics is you have to replace the entire denture tooth. You might do that with milled acrylic. You might grind out the tooth and then bond in an acrylic denture tooth, or in some cases you can repair that with composite.
All right. Okay, I'd like to squeeze one last question in. What happens if one of the 4 implants fails 3 years later? Are there any guarantees, warranties on the work rendered?
Generally speaking, as I understand it, warranties are at about a year from most manufacturers. Beyond that, there may not be any, and you would want to consult with whatever manufacturer of the implants as well as the laboratory about warranties, and that can vary widely from lab to lab. As far as the prosthetics, what I generally see is the labs warranting items anywhere from 1 year to 5 years. I don't think you're going to find anything greater than 5 years out there. So, you know, in our hands, we typically fix most anything that happens within the first year. But then beyond that, there has to be some sort of prorated charge.
All right, everyone, we will do a hard stop here on the Q&A. And I just want to say thank you, everyone, for attending Microdental CE webinar. We look forward to your participation in our upcoming webinars. And thank you, Dr. Strong, for your partnership on this speaking engagement. If you have any follow-up questions, feel free to reach out to Dr. Strong directly. And today's webinar with Dr. Strong is part of a series of 3 total, this being the second. The third part will be next Friday, May 15th at 11 a.m. PST. It is titled New Normal Prosthetics for Implant Over Dentures. Dr. Strong, would you like to briefly elaborate on this next course?
Yes, I will illustrate again. Traditional technique for denture construction and overdenture construction versus the fully milled construction, and a really nice expedited technique for your overdenture construction using scanning and milling technology. As well as I want to illustrate the method of the technique for gaining centric relation at the correct vertical dimension using a Gothic arch tracing device, which actually is very simple and can be relied upon with a lot of accuracy and probably solve a lot of our problems that we may have had in the past in gaining an accurate centric relation. So I look forward to the next webinar.
All right, well, thank you so much, everyone, and thank you again.